Hello everyone. So today I will discuss about the thought process that everybody should have while writing the notes of a critically ill patient. So whenever I write notes in my patient, I divide my notes based on these four things: pre-data acquisition phase, the data acquisition phase, the data interpretation, and the formulation of plan. So let us discuss one by one. So along with the explanation, I'll provide you with a case summary step by step and let us see how it works. Number one is pre-data acquisition phase. Any patient you are writing note, you should be having some knowledge of the history of the patient. Not detailed history, but at least focused history. Number 2 point, you must be having the medical or relevant surgical history. This is past history, right? Any intervention in the recent past, especially when this patient has come to you, the patient must have been through the year. So treatment received in the year. If you are examining the patient after the patient has come to the ICU, you must have specific handover. That is the treatment he has received so far in the ICU. So these are the pre-data acquisition. Based on these things only, we will go to data acquisition phase. Let's take one example. A patient came to here with complaint of drowsiness, fever, abdominal pain, vomiting. Is a chief complaint. The patient had a history of diabetes mellitus type 2, was on metformin, SGLT inhibitors like dapagliflozin, acrobosh. Patient is having hypotension, is on stamlo. There is no surgical history of the patient at this present moment. Neither patient has received any intervention in the past. These are the findings of the patient in the emergency. Because of the altered mental status, GCS was less than 8, so intubated in the emergency. Right? But done on ABG in the emergency, it shows severe metabolic acidosis. This we are discussing specific handover or treatment received in the year. pH is 7.0, bicarb is 4.0, PCO2 is 10, lactate is 3, potassium 3.5, sodium 140, chloride 112, and CBG is 450, very, very high. Right? So this is the ABG they have done in the emergency. And what treatment they have given? 1 liter of fluid bolus given. Then we started at 150 ml per hour as maintenance. This is normal saline. In the ventilator, patient is requiring FiO2 of 0.35, SpO2 is 100%, tidal volume is 450 ml, respiratory rate is 24 per minute, and of course they are giving a PEEP of 5. So with this treatment, patient has now come to your ICU. So in the ICU, with this background information, now I examine the patient. Now comes the data acquisition phase. In the data acquisition phase, what are the things? Number one is examination of the patient. So many of the data of the patient we can get by simply examining the patient. Right? Number two, from where the data we should get? By examining the patient surrounding. What is there in the patient surrounding? Number one, ventilator. Number two, infusions, specifically any vasopressors or inotropes or other like fluids, like insulins or others. Right? Number three, in the patient surrounding, you will check for the urine output. And number four is any additional devices. For example, this kind of patient may have advanced hemodynamic monitoring like flow track, Vigilio. Patient can be having CRRT, ECMO, plasmapheresis, anything. So you have to examine the patient surrounding. In the surrounding, whatever things are there, you have to acquire data from them, right? Number three is examining the nursing chart. So from the nursing chart, we will get temperature, intake output, that is fluid balance, trained in hemodynamics, trained in ventilator support, bladder and bowel habits, right? These are the things we'll get from the nursing chart. Number four is some lab test, imaging, cultures, or any specific investigation. Number five will be ABG. And number six, medication chart. In this specific patient, number one is patient examination. We examine the patient look dehydrated. Because patient came with abdominal pain and vomiting, we examine the abdomen, it is non-tender. And there is no palpable mass in the abdomen, right? And of course, you have to perform a head to toe examination, and this is normal. Number two is examination of the surrounding. So first is ventilator. It is same as in the ER. Number two is infusions. Patient is having no adrenaline infusion. Patient is having insulin infusion. Patient is having IV fluid normal saline at 150 mils per hour. These are the data we're acquiring from our patient, right? We check for the urine output. Urine output is 30 to 40 ml per hour. So here you can say that patient is having oliguria. And urine also, ketone is positive. From nursing chart, we get the information that patient is having low to moderate grade temperature throughout, and in the intake output in the last 12 hours since the patient was in the emergency, he has received around 4 liter of fluid and output is only 400 ml. In the investigation and imaging, WBC count is 16,000, neutrophil is 80%, urine we have 100 pus cells, urea is 100, creatinine is 1.8, potassium is 3.3, chest x-ray is normal, 2D echo is suggestive of a normal heart with IVC of 5 millimeter. Right. Number 5, ABG we repeated here. pH is 7.0, PCO2 is 20.0, bicarbonate is 8, lactate is 5, CBG is 400. So in the pre-data acquisition phase, we took the history, the medical history in the past, any intervention in the recent past, treatment received in the year, and a specific handover. If you see in the emergency, the ABG they've done, the ABG suggests here the metabolic acidosis is actually a high anion gap metabolic acidosis. Why? Because sodium is 140, minus chloride is 112, minus bicarbonate is 4, that is 24. This is a high anion gap metabolic acidosis. And the PCO2 is 10 here, which has become 20 here. That means patient is also having a respiratory acidosis. So this compensation for metabolic acidosis is inadequate. If you see the chloride is 112, that means patient is also having a normal enantiate metabolic acidosis secondary to hyperchloremia. Also, patient presented with vomiting. If you calculate the delta gap, you will find patient is also having a metabolic alkalosis. So, four acid-base problems are there here. So, we are already interpreting the data. So, now let us come to data interpretation. In the data interpretation phase, there are only three things you need to be careful about or you need to interpret. Number one is any acute change that requires acute response. Number two is recognize patterns. And number three, a response or outcome of specific interventions. So as you have seen, we have already discussed, already started to interpret the data. Our patient has severe metabolic acidosis. And this metabolic acidosis is due to diabetic ketoacidosis because sugar is very, very high. We have checked urine, ketone is positive. So, urine, ketone positive. We have a severe acidosis. So, bicarbonate is less than 18 and CVG is more than 400. So, patient is having decay that is causing severe metabolic acidosis, and this is high enantiate metabolic acidosis. Also, the severe metabolic acidosis can be due to increased lactate. If you can see, the lactate is 5 here, so the lactate can cause severe metabolic acidosis. The lactate increase can be due to increased blood sugar, causing dehydration, hypoperfusion, secondary to sepsis, because you have seen TLC is increased, patient is having fever, and also patient is having urine more than 100 parcels. So sepsis can cause hyperperfusion, blood sugar can cause dehydration, that can cause increase in lactate, producing a severe metabolic acidosis or high enantiate metabolic acidosis. We also see patient is having normal enantiate metabolic acidosis. The standard iron difference is less than 34, that is sodium minus chloride, which suggests there is a hyperchloremic metabolic acidosis. This is due to using normal saline in a large amount, right? Also, this patient is having respiratory acidosis. And this is due to the faulty setting of the ventilator. This kind of patient, they require a high minute ventilation. So, this is due to faulty ventilator setting, right? And also patient is having metabolic alkalosis from delta gap, and this is due to vomiting. The vomiting has caused acid loss, causing metabolic alkalosis, right? Also, this patient is having shock as manifested by NORAD plus lactate despite fluid infusion. The shock can be due to decay and dehydration. Shock can be due to septic shock from urosepsis and can be due to severe acidosis causing myocardial dysfunction. Also, patient can have catecholamine insensitivity due to sepsis. If you see other things here, you can see the potassium is 3.3. So, the hypokalemia in this situation can be secondary to giving too much of fluid, causing dilutional hypokalemia. Because of insulin for decay can cause hypokalemia. Correction of acidosis can cause hypokalemia. And another pattern that you need to understand here, patient is receiving SGLT inhibitor, that is dapagliflozin. So this kind of inhibitor, SGLT inhibitor, They decrease blood sugar by causing glucosuria. So glucose in the urine can cause UTI. They UTI can progress to urosepsis and septic shock. These urosepsis in a DM2 patient can precipitate diabetic ketoacidosis. So this is one of the major patterns that you have to understand in this situation that is causing all sorts of problems. So this is our interpretation. In the formulation of plan, there are three things. Number one is treatment specific to data interpretation. Number two, treatment to attain homeostasis. Number three, new treatment strategy to improve condition. These are the basic three things in the formulation of plan. So in our case, let us see what are the things we can do. So start giving fluid according to DKA protocol. Here sepsis is also there, but the DKA protocol will cover for sepsis fluid also. So give IV fluid and will avoid normal saline because there is a hyperchloremic acidosis. We'll give plasma light. Right. You can give 500 ml per hour into 4 hours. Then 250 ml per hour into 8 hours. Then 150 ml per hour to continue. Target a cumulative balance of approximately 100 ml per kg in 24 hours. For a 60 kg person, at least 6 liters of fluid. Right? This is very, very important. Number two is we have to optimize the insulin. You may need to increase the IV insulin by 1 across the board, or you may add Lantus insulin. Number three is because you are using insulin, patient is having hypokalemia, correction of potassium. At least potassium should be more than 3.5 before starting insulin. Number four is patient is also having shock secondary to urosepsis. Start IV antibiotics. In this case, we'll cover for ESBL, so we'll start meropenem. And we'll send for urine culture and blood culture. Number five is we stop all the oral hypoglycemic. Only insulin. Number six is, as you can see here, patient is severely acidotic. So here we may give bicarbonate boluses and then isotonic soda bicarbonate infusion to correct for the acidosis. Of course, insulin and food will correct the acidosis, but acutely, when patient is hemodynamically unstable, we can give bicarb boluses. Number seven, we can see patient is having respiratory acidosis due to faulty ventilator setting. So increase the tidal volume to 500 ml. Increase the rate to 30 per minute. Right? Patient requires high need ventilation to compensate for the acidosis. So as the patient is getting treated, the acidosis will get resolved. At that time, you can come down on both of these things. Right? Second is treatment to attain homeostasis. What are the treatment we give to attain homeostasis or to maintain homeostasis? We use PPI. We use Clexane. We keep the hemoglobin more than 7. We keep the head end elevated by 25 to 30 degrees wherever possible. We give trophic feeds. We use sedation and analgesia. All these things. So this is basically the first hug. So the first hug is usually done to maintain homeostasis. And a new strategy here to improve outcome because patient is having urosepsis. Once patient is stable, we can do a NCCT KUB. Before that, we can do a USG whole abdomen, specifically looking at the kidney, ureter, and bladder for any hydronephrosis or pyelonephritis. So these are the tests depending upon the clinician's choice we can do. This is new treatment strategy to improve condition. And of course, we require multidisciplinary approach. And to say not the least, urine ketone, ABG every 6th hourly, check for BMP every 12th hourly. Number 12 is goal. Our treatment goal will be to decrease the blood sugar by 50 to 75 mg per dl per hour. Bicarbonate to be increased more than 18. When this is achieved, patient can take PO diet. We need to change IV insulin to basal and bolus. We need to look for the lactate clearance. We need to taper up the NORAD. So this is how, whenever you are writing a note, this is the thing you have to take care of. So we have clearly discussed how to write a note. To start with, pre-data acquisition phase, where we take the history, take relevant medical and surgical history, treatment received in the year, and specific handover. In the data acquisition phase, this is the most important phase. We are actually standing beside the patient, looking at the patient, his surroundings, examining the nursing chart, lab test, imaging, culture, specific investigations, ABG, medication chart, and based on the data acquisition, we do data interpretation. From data interpretation, our diagnosis will come. And from our diagnosis, our management plan or formulation of plan will come. In the plan, we have a specific plan for the data interpretation. We have plan to maintain homeostasis of the patient, and specific strategy to improve outcome has to be there, and our goal of treatment has to be there, and how to monitor the patient. So this is how I write note in my ICU patient, and this is how we should think about our patient while writing ICU notes. Thank you very much.